not be good, as in its movement may be less, as in Hysteroscopy, or it can be abnormal shape and it's Hysteroscopy. All these reasons which depend on sperm production can, or its production either quantity-wise or quality-wise, can lead to infertility in the male. So after the sperm is produced, it is transported outside through certain tubes. So if there's any block in this passage, then that can again cause the rise to infertility. So these are the causes in male. And there may be some systemic causes as well which may affect these, such as diabetes, thyroid issues, or it may be pituitary hypothalamic issues. So all these are hormonal issues as well. So all these can in turn affect the fertility of the male. So likewise in the female. So in the female we have the egg. Like I told you, the egg needs to be produced in the ovaries. So there's anything that hampers this production, and usually after a particular age, the eggs in the female starts decreasing. So it could be age related, or it could be immunological. That is, there could be some antibodies produced against the eggs in the ovary, and this in turn can lead to less number of eggs. So this can also give rise to infertility. In addition, systemic causes, hormonal causes like endometriosis, Pcod, and thyroid diseases, diabetes, all these can also cause effect on not just aspects of the female reproductive tract and lead to infertility. In addition, the egg here again has to be transported to through pathway to reach the sperm. So if there is any defect in this pathway, then again the egg may not be able to reach the sperm, and we may not be able to have a conception. Now even if all these things are fine, the egg reaches the sperm, the embryo is formed, but still sometimes everything can fail. This is because there may be problems in the uterus which prevent this embryo from implanting into the uterus. So you see, fertilization and conceiving is not a very simple process. It is a complex interplay of various factors, and at several stages there could be glitches, and there could be reasons which may result in failure in conception. So which is why we need to diagnose where the problem lies and then treat accordingly. But now technology is so advanced that I would like to assure most of my friends that most of them could use some kind of technology to conceive. There is some way or the other. It is just a permutation and combination of all these technologies, and it can help you conceive. So once you reach the fertility expert, it is our duty to diagnose where the problem lies and then give you the right modality of treatment to conceive. So now what are the different treatments? Before treatment, let's discuss diagnosis. So what are the various tests that are available to enable us to detect where the problem lies? Usually, we ask the couple to come together to the fertility specialist so we can evaluate both of them at the same time. So there have been instances when patients come to me and say that my male partner or male partner doesn't want to come. Please evaluate me first, give me the treatment, and in case we detect something, treat me first and then look at them. But I would generally advise a couple to come together and start the diagnosis itself, the investigation simultaneously, so that we can treat them together. So a lot of time is wasted if we start with one person and then we detect that there's something is wrong with the other person. For example, I could keep treating, maybe the lady has PCOD and I can keep treating her for it, and I've not even evaluated her male partner. So by the time I cure her, say it takes 6 months to a year, and then see that the male partner has azuspermia, doesn't have a sperm at all. So where is the question of me treating just so please make sure that you visit us together and we start your evaluation together. So now coming to the investigations. So in the male, a basic semen analysis is very, very important for us. This semen analysis doesn't affect the male in many ways. It's very easy, doesn't hurt him in any way. So all he needs to do is to give us a sample after 3 days and with 5 days of abstinence. So this sample will tell us a lot. It will tell us what the ability of the male is to conceive. So if there's a problem with this, then we do additional tests like a D5, that is known as DNA fragmentation index, and probably several other hormonal tests or a systemic test to see if there is any other problem, like an ultrasound and of the scrotum, and why there is a variation in the semen analysis. But if the semen analysis is normal, there's nothing else to expect from the male partner. Now for the female partner, we have a whole lot of tests that are involved. So one is, like I said, first we need to determine whether the eggs are present at all and how many of them are there. So this can be done with the help of what is known as an AMH level. So this is a hormonal test which determines the number of eggs in the female. Apart from that, we do a pelvic scan where we see the entire reproductive tract. Then of course we have certain hormonal tests like a thyroid test. Then we have what is known as FSH and prolactin. These are again certain hormones. All these help in menstruation and ovulation, that production of an egg and release of the egg. So all these hormones are evaluated. Then of course systemic diseases are also evaluated, like whether the patient has diabetes, thyroid, and a lot of serological tests to test for infection. If all this is fine, we also ask the patient to do what is known as a tube test. Now this is a slightly painful test. Yes, I agree it's painful, and a lot of them are hesitant to do it in the first instance itself. So there are some clinicians who practice doing this test after treating the patient for a couple of months, say 6 months or 3 months, and if that fails, then going ahead and doing the tube test. But personally, I would advise the tube test in first instance itself, because we've had several patients who have received several cycles of treatment. They have even undergone IUI, maybe 3 IUIs, 4 IUIs, and still everything fails. And instead of wondering what else could be wrong, we've just done the tube test, their tubes are blocked. So we have subjected the patient unnecessarily then to a lot of other treatments and hormonal injections and so many other drugs, without even ascertaining that the basic cause was a tubal block. So all we had to do in this case was single IVF, and the patient conceived the next cycle. That is why the tube test is very, very important. So once we have done the tube test, once we've evaluated both partners, then we usually, depending on what the cause has been detected, then we start off on treatment. So usually the various modalities of treatment are present. Like I said, it is very cause related, but just to give you a broad guideline, we'll start with, when couple come to me in the first instance, I take their history, then I subject them to the investigations I spoke to you about, and then I usually ask couple to start with, if everything is fine, that is, if there's nothing much on either side, then we start with what is known as ovulation induction drugs. So we give certain tablets. So for 3 cycles to 4 cycles, we give these tablets. This is to stimulate the eggs to grow. Then we monitor the growth of the eggs with the help of follicular scan. So we keep seeing whether the egg is growing or not growing with the help of the scan. This is done regularly from 8th day onwards, say at intervals of 3 days. And when we see that the egg has grown to a particular size, then we ask the couple, we give them an injection we give the woman an injection to induce ovulation, that's to release the egg. And following that, we ask the couple to have timed intercourse. So this is the fertile period. So this is the period when the couple is likely to conceive, because the egg is going to be released, and having intercourse around that time may aid a conception. So we have a couple to have intercourse around that time of ovulation. And then following which, we test for a pregnancy after 2 weeks to 20 days of time. So this is how we do. So this is known as ovulation induction, and we try this treatment for 3 cycles to 4 cycles. Now we've seen that most of the couples, 90% of the couples should succeed with this treatment if there is nothing else involved. But if in spite of 3 cycles, the couples fail to conceive, then we don't waste much time. Like, we can probably give to 6 cycles of ovulation induction, but if best results are achieved within the first 3 cycles, the cumulative rate is very high in the first 3 cycles. Fails to conceive within 3 cycles, known as IUI, or intrauterine insemination. So as you know, this is the next step. Here what we do is, we take the husband's sample, we process it in machines, we make it into, we load it in an injection, and we inject the sperm, the concentrated processed sperm sample of husband into the uterus of female. This is known as intrauterine insemination. So this is possibly 3 times more successful than a ovulation induction. So in ovulation induction, that is the first step which I described, we can say a couple has 10% chance of conceiving. But with IUI, I would say that the chances are somewhere between 25 to 30%. So it's 3 times more effective than ovulation induction. Of course, there's a lot of literature where they say that IUI is not very effective, it's only 20% or is as good as timed intercourse. But personally, we have seen these kind of results in our institute, which is why I'm saying it's much more successful than normal ovulation induction. So even the IUIs, we try for around 3 cycles. And if the patient is maybe even a 4th cycle, but not beyond that. If the patient doesn't conceive within 3 to 4 cycles of IUI, then we proceed with what is known as IVF. But before that, we would want a diagnostic hysteroscopy or laparoscopy. So this is a small test. Of course, it's an invasive test where we pass an endoscope into the uterus as well as into the abdomen to see where the fault is, or if there's any fault that we could have missed with scan and other tests. Usually sometimes we see that endometriosis is one such disease which can be diagnosed only by laparoscopy. It may not be evident when we've done a scan. So this could be missed, and this could have led to the long lasting infertility or the resistance to treatment. So anyways, so we usually do what is known as a diagnostic hysteroscopy, laparoscopy at this stage, and then depending on if we can have a treatable cause, we treat it. If not, we proceed with what is known as an IVF. So these are the whole range of treatment that is available in infertility. So depending on what the problem is with you, So we decide what best treatment to give you. So sometimes we may put you to the whole gamut of treatment, or sometimes we may even say that we'll have to start with IUI but no ovulation induction. Or in some cases, like I said, if there's a tubal block, there's no other way. I mean, of course, we can do a surgery to try to, cure the disease. But if the tubal block cannot be cured or cannot be treated surgically, then, or if we fail to cannulate it, like open the tubes up, then we directly insist on an IVF. So depending on where the problem lies, we'll have to treat you accordingly. Yeah. So fine. So I think now we'll just, I've received quite a couple of questions. So we'll take a small break now. I would like to, after this, we'll come back and I would like to read out a couple of questions depending on your, what doubts you people have already sent. And if depending on my talk, you have any more doubts, please click on the link and send the questions across. I'll be very happy to speak about it. Hello everyone, we're back again. So thanks Uday for sending me this question. So I've seen that so most of the questions seem to be quite a few questions on polycystic ovarian disease. I'm not surprised because that seems to be one of the most common causes for infertility nowadays. So yeah, Uday has asked me as to what are the causes for PCOD. So PCOD is a multifactorial disease. So what I mean by that is that there's no just one cause for it, and which is why there's no just one step treatment for it. So in PCOD, what really happens is it can be genetic, as in it can be passed down in families, or it could be due to lifestyle. So lifestyle factors such as increased weight, abnormal diet, that is including lot of processed food, lot of carbohydrate rich diet, or use of saturated fats, all these things can give rise to PCOD. And apart from that, lack of a healthy lifestyle, as in lack of an exercise schedule, so this can also give rise to PCOD. So PCOD is basically all these factors which I said, that is increased weight gain, abnormal diet, lack of exercise, or even an unhealthy diet that includes substance abuse, alcoholism, smoking, or lack of a proper sleep pattern. All these can give rise to PCOD. And increased stress in the workplace, so this can also give rise to PCOD. So, so what really happens in PCOD is that all these causes can give rise to hormonal changes in the body. So these hormonal changes can form small cysts in the ovaries. Cyst means, if you mean by cyst we mean water-filled bubbles in the ovaries. And these bubbles prevent the eggs from being released from the ovary, and this is what gives rise to the main problem in polycystic ovaries. Yeah, next one. So there's the, so this is some of the causes for PCOD. One of the other question that I received was from Ranjita. So Ranjita wanted to know how a PCOD woman can get pregnant. So I just explained to you now what are the causes for PCOD and what really happens in PCOD that prevents a woman from getting pregnant. So like I said, these cysts that are formed may prevent the egg from developing in the ovary and prevent it from getting released as well. Apart from that, even if ovulation occurs, even if an egg formation occurs, sometimes the hormones changes that are associated with the polycystic ovary can cause changes in the endometrium, and it can prevent implantation. That is, it can prevent the embryo from getting attached to the uterus and pregnancy from occurring. So how a PCOD woman can get pregnant? She can get pregnant if we ensure that first, when eggs are not being formed, we ensure we give medication to help in formation of these eggs. We give medication to help release these eggs. Then of course we try to make sure that they have either timed intercourse at the right time or with IUI. But the underlying PCOD has to also be treated simultaneously. So we usually don't say like treat PCOD first and then go ahead and try to conceive, because there's no definite time frame for PCOD. There's no definite treatment for PCOD. So I can't tell you that I can treat you for 3 months and you will conceive after that, or your PCOD does resolve after that. So we start the treatment for PCOD simultaneously to decrease the hormonal load, and also treat the patient to get pregnant also simultaneously. So another thing that Kurat has asked me is that she's been having PCOS and she's married from the last 1.5 years, she's been trying for a baby. So her question is probably how to go about it. So 1.5 years, usually for everybody else, like I said, 1 year of regular unprotected intercourse, and if you've not conceived, we say that okay, we can go ahead with treatment. But in case of PCOD patients, if after 6 months the patient has not been able to conceive with regular unprotected intercourse naturally, then we ask the patient to meet the fertility expert and of course get treated for PCOD, but simultaneously start off on some treatment to enable you to get pregnant. So I already told you the range of treatments. So it can start from simple ovulation induction to IUI to IVF, and sometimes we even advise what is known as ovarian drilling for PCOD. So all this depends from patient to patient as to which patient deserves what. So we do the hormonal profiles, that is LH, FSH levels, the AMH levels. So we see how varied the hormones are, and depending on that we tell the patient which treatment suits them. Of course, the age of the patient is important, and here again we also need to know the weight of the patient and how many years of married life has elapsed since they got married. Yeah. So so which is the best fertility treatment, Fauzia has asked, for PCOD? Is it IUI, IVF, or ovarian drilling? Like I told you, this depends from patient to patient. How we determine which treatment is best is, like I said, it depends on the number of years of married life, the age of the patient, and most importantly, we do the hormonal levels. So the LH level and the AMH level is very important for us to determine we can just stick fertility treatment or whether we need a ovarian drilling before going ahead. Now, if the AMH level and the LH level are high, then we usually advise the patient to treat the PCOD first before trying fertility treatments, to go ahead to do a ovarian drilling and then go IUI or IVF. Because by just doing ovarian drilling, the hormone levels fall and it gives us an optimal environment to go ahead even with an IUI or IVF. So the IUI IVF is more likely to be successful when we do a ovarian drilling. But for some patients, the hormone levels may not be that variable. In these cases, we could go ahead directly with an IUI or IVF and need not subject the patient to laparoscopy. Now we'll take a short break again. So I'll go through some more questions and we'll get back. Thank you. Welcome back, everyone. So Vijay Lakshmi has this question that will egg count be increased with medications after 32 years old? Well, unlike a male where the sperm is produced on a day-to-day basis, the eggs in a female are fixed and limited in number. So when a female baby is born, the number of eggs are already present in the ovary. So there's no eggs being produced every day, on a fresh basis. So the number of eggs are fixed and they remain in the ovary. And as the person ages, these eggs start getting depleted. So once the person attains puberty and then every cycle one of the eggs is released during a menstrual cycle, during ovulation, and so the eggs keep decreasing in order after that, and after the age of 30, this decrease in eggs is slightly accelerated, and after 35, this rate of depletion increases much further. So which is why we try and counsel the patients not delay their first pregnancy as much as possible. I know currently we have a lot of career issues and a lot of female working and joining workforce, achieving a lot of things, which is why having early pregnancy might hamper a lot of other things in their career. But sometimes when we look at the number of patients suffering from infertility issues, and most of them being age related, we usually, I think the age-old way where our grandparents or whoever used to tell us to conceive as soon as possible might hold some kind of weightage, considering that the eggs keep depleting with age. So now, can the egg count be increased with medications? Currently, there are a couple of medications, but they've not been proven to increase the egg count. So they may be in the form of DHEA or coenzyme Q or certain antioxidants. So there are certain conditions where the eggs get depleted at a faster rate than normal. So this is seen in some cases. Then we call it as premature ovarian failure or early menopause, where the person's eggs deplete rapidly even before they reach that particular age. So like Vijay Lakshmi has said, maybe around 30, 32 years old, we see that these people don't have eggs at all. So in these cases, we have tried these medications, and these medications have given some people hope. But they are not hard and fast rule that they will work, and nothing, it's not like proven to be 100% effective or even 80% effective, though they're not that effective at all. So we give a course of 3 months, and if all things don't work, then sometimes we either, if the patient is particular, we advise them to go ahead for IVF if the egg count is very limited, or if it is totally unreasonable to go ahead even with IVF and the AMH level is very low, then probably it would be wiser to go ahead with a donor oocyte or a donor egg to get better results. So the next question. Yeah. So now he also has less active sperms after the infection. So what is the best treatment that we can go for? And I've been taking treatment from last 1.5 years, but no results yet. So we have seen such an incidence in the current pandemic where the sperm, not so much on count, but the health of the sperms, the movement of the sperms has come down following a COVID infection. In fact, there have been cases where COVID has been, the virus has been detected in the sperm sample as well, which is why when patients are suffering from COVID, we advise them to abstain, to stay away from intercourse. Anyways, so yes, this is a possibility that the health of the sperm is affected. It can cause Estenopermia, that's decrease in the motility of sperm. So in such cases, there are certain supplements and a healthy diet and recovery with proper exercise, diet can help in improvement of the sperm to some extent. But if that fails after 3 months of giving supplements, if it has failed and there's been no improvement, then I would advise IUI, where we process the sperm in a machine and we add certain nutrients, certain factors, vitamins which benefit the sperm, and that may in turn improve the sperm quality and health and give us a better result at conceiving. Of course, if that fails also, then maybe an IVF will be necessary. But we've seen that most often the supplements have helped, and even an IUI goes a long way in helping such cases. Arva has a question that her ET lining never goes beyond 6. Is it because of fluid formation? What can I do for that? By ET lining, we mean the endometrial thickness. This is lining which lines the uterus. This is for people who are not aware. So yes, there have been some cases where the endometrial thickness hasn't increased or doesn't increase. So sometimes it could be due to the medications that we use for enabling infertility, like clomiphene. But that's something that we know. When we come to once we are given the medication and the thing is not improving, then the next option for us, once it does increase, is to give what is known as estrogen supplementation. So we give them some tablets or some creams or gels which are estrogen gels or creams. So these in turn are known to increase the thickness of the endometrial lining. But sometimes even when we give these medications at a high dose, the endometrial lining may not increase, and this directly has an effect on the implantation. So even if we go for an IVF, we want the endometrium to be at least a minimum of 8 mm. 8 millimeters, and if that doesn't happen, then it's unlikely that the IVF will succeed. So which is why if this is not happening, then consistently, and we see that we have given them supplements and you have taken estrogen supplements, and there are some other supplements like arginitric oxide donors. I mean, these are nitric oxide donors, so it is a powder, it's a sachet which we give. And apart from that, we also give some sildenafil citrate and aspirin. So if all these drugs have failed to improve the endometrial thickness, then there are some newer modalities of treatment that has come out. So we usually look at PRP, or platelet rich plasma. So where the plasma, that is a component of the blood from the patient, is drawn, and it is enriched with platelet and growth factors, and this is again put back into the uterus to increase the endometrial thickness. And there is another entity also where we also put back several growth factors into the uterus, and this is known as it's available in a form of injection. So this can be given intrauterine and can help to improve the endometrial thickness. And this is usually done in conjunction with an IUI or an IVF, and there have been instances when these have given good results for a lot of people, and it has helped a lot of people to have a successful pregnancy following IVF. And in addition, probably Arva, I would advise that in case it's possible to get what is known as ERA, that is Endometrial Receptivity Assay. So this is a small biopsy where we test the endometrium, and it will tell us which is the ideal period for transferring the embryo during an IVF procedure. And sometimes the thickness may not be optimal, but when an ERA is done and it shows that the endometrium is receptive around that time, so going ahead with an embryo transfer, irrespective of the thickness of the endometrium at that time, may give us a good result as well. So these are some of the modalities that I would advise in case your endometrial lining is not getting thick. And yes, if there is fluid formation, it shows that there is an infection of your endometrium. So probably that has to be treated first, and then look at the other modalities for increasing the thickness. Yeah, we'll take a break now, and we'll come back with the other. Welcome back, everyone. So we have a question here which says that my wife has endometric problem, I think a problem with the endometrium. So this person has had a problem wherein the endometrium was 5 to 6 and they've taken the PRP treatment, and the thickness has not has increased only from 6 to 7 in spite of it. They've been IVF 7 times, married for 14 years. Wife is only 32 and does many treatments but still not able to conceive the baby because of the endometrium. So here I'd like to know if the cause for the endometrial thinning has been understood, as in I want to know if you've done a test for tuberculosis. This is very common in India, where tuberculosis or the endometrium, that is has been detected when we do what is known as hysteroscopy and biopsy. So I'm assuming that you've done this test and probably it's negative, that is you're not suffering from any tuberculosis. So in some cases this endometrium becomes very thin, probably because of an infection or due to previous procedures or surgeries on the uterus, or sometimes when the hormone of woman itself is too low and the endometrium does not respond to these hormones. So like I told you earlier, there are all these supplements. If you've used that and if you've tried PRP, then there's something known as BAPC as well, which again is biologically active peptide concentrate. So these again is a concentrated set of growth factors from your blood of your wife, or even stem cell therapy which can be put in intrauterine. If all else has failed, then the only other alternative left is to probably go for surrogacy. But unfortunately now in India commercial surrogacy is banned, and this is going to come into effect from 25th, as in we won't be able to hire a surrogate by paying money as we used to do so earlier, and but we can go for surrogacy if you manage to get a surrogate within your family, or any of your family members are willing to carry this child for you. So then that's the other alternative that is left back. But yes, on the personal front, I would like to say that though it has not been proven, a couple of my patients have tried alternative therapies. So some of them, along with the IVF, in conjunction with IVF, I've had a couple of patients who have tried acupressure, acupuncture, and it has given them some good results. And there have been at least 2 cases who have succeeded along with the IVF and the acupressure being carried out simultaneously. We have seen cases which have succeeded with that. If all else fails, and considering that surrogacy is not a very good alternative option for most of us now, maybe you could try that as well. And there have been instances in people who have even gone for Ayurvedic treatment during the course of IVF to just increase this lining, and that has helped as well. So maybe because commercial surrogacy is something that I can't give you as an option now, if you don't have a surrogate in mind and if everything else has failed, then you can look at these options also. Then apart from that, there's another couple which has asked me that so they are willing to go for commercial surrogacy. In fact, they've had a financial agreement with the ART bank, but no agreement with the surrogate mother yet. Now, since it's been banned in India from 25th Jan, would the agreement with the ART bank stay valid? So I'm not really sure what are the legal implications here, because honestly speaking, we knew that this ban was going to come into effect. So most of us have stopped commercial surrogacy, and it's been almost more than 2 years since we at Smile Baby IVF have stopped, because we knew that such a law is going to come into effect. So it just took much longer than needed, probably because of the pandemic. They took long to pass it as a law, and the law is very stringent and it's very clear. Commercial surrogacy is not going to be allowed. So if someone has already transferred their embryos, then probably the agreement still holds good, and then they can be allowed to deliver the child. So this was something which was told to us almost 2 years back, whereas we had transferred embryos and this law was going to come into effect, and we knew that we had to deliver the couples that we commissioned already. But if there's no embryos and it has not been transferred and the surrogate is not carrying your pregnancy right now, then I doubt if it's going to be allowed. I doubt if you can keep up with the agreement any further. But anyways, I'm not really sure of the legal implications. We'll have to wait and see how it goes. Thank you. Welcome back. So this is another question from Mahalakshmi. My age is 36. I am suffering from spinal tuberculosis and taking medication since 6 months. I have 3 years old baby boy and I am looking for a second baby. Can I consult the gynecologist to conceive now? So yes, so since you're already on medication since 6 months, the treatment for, I think, spinal tuberculosis for 9 months. So it's better to complete the course of treatment and then approach your gynecologist. In the meantime, it's better to also start with a folic acid supplement. Most probably you must be already taking a vitamin supplement along with your anti-tubercle drugs. So the drugs per se don't come in the way of your conceiving, and even the spinal tuberculosis may not affect your chances of conceiving. But why I'm asking you to wait is that it's better that you finish the course of treatment and you make sure that you're completely cured and healed before you go for it. Because in case you manage to get pregnant after this, then there are a lot of changes that can take place in your spine. It tends to relax, the ligaments become softer. So whether your back will be able to take this load or no of a pregnant uterus. So all these things have to be ascertained. So it's better that you complete the course of treatment. Meantime, start with folic acid supplementation, and considering your age, it's also better that you take at least minimum 90 days of folic acid prior to conceiving. So in the meantime, you would also finish your course of treatment, certain whether it's been successful or not, and then go ahead with a conception. Next question. Earlier during my talk, azuspermia is a condition where the sperms are absent when in a male sperm sample. So when we ask for a semen analysis, we see that there are absolutely no sperms that are visible in that. So this can happen in two cases. One, the sperms may not be there at all in the person, that it may not be present at all. So this is known as non-obstructive azuspermia. Or two, obstructive azuspermia. Obstructive azuspermia is when the sperms are being produced in the male, but like I said, it will come out through a particular pathway. So maybe this pathway has been blocked. These tubules are blocked, and so the sperm is present in the male, but we are not able to collect it. So this is known as obstructive azuspermia. As you know, obstructive azuspermia can be treated, as in we can sometimes undergo microsurgery to treat this obstruction, but most often that's not advisable, because the obstruction, the level of obstruction at which part of the pathway is obstructed, it's very difficult to ascertain this, and usually multiple obstructions may be present. So most often when a person presents with azuspermia, we ask for certain hormonal levels to determine whether this is obstructive type of azuspermia or non-obstructive. That is, whether the production of sperms itself is not possible due to some hormonal reasons. And we see that if it is non-obstructive azuspermia, as in the sperms are not produced at all or are immature, then there's nothing much we can do. But if the sperms are being produced, and if it is not able to reach us, then we do what is known as sperm extraction. So this can be done with first we diagnose whether the sperms are present or not in the testis. This can be done with the help of TISA, that is testicular sperm extraction, PISA, that is percutaneous testicular sperm extraction. So these are small surgical sperm retrieval techniques where we use a syringe or take a small biopsy from the testis. We determine whether the testis has sperms or not, and depending on that we go ahead with an IVF or ICSI procedure, that is intracytoplasmic sperm injection. So this is what we do if the person is suffering from azuspermia. Thank you. everyone. So we have a question from Shamali which says, my age is 38. I'm trying to get pregnant. What are the challenges to get pregnant without IVF? So yes, Shamali, like I said, fertility itself is an age-related issue. So as we age, especially in the women, the eggs start decreasing. So it's very important that initially, before you try to get pregnant, you can certain hormonal levels, especially a AMH level. So we need to see what your AMH is. So that will tell your reserve of eggs that are present. So whether you have eggs, and so it roughly gives us an indication as to how many you have and how healthy your eggs are. So this again will tell us what your ability is to conceive. So this is one of the major factors. Then of course the other usual evaluation for fertility needs to be done as to whether your tubes are fine and all else. So I think the biggest challenge considering your age would be the AMH level. So if that is normal, which is possible, a lot of people even at 30, the AMH is normal, then you stand a very good chance to conceive. There is nothing else that can probably hamper. But of course, before trying, it's also, even as you're getting your evaluation done, it would be advisable for you to start with your folic acid, so that considering your age, that will help in you achieving a healthy pregnancy as well. The other question is from Ananya. My age is 40. And I have a first baby who is 2 years old and has had, so that baby was through IVF, and has had a risk of ASD, atrial septal defect. Do I need to consider trying for a second baby through IVF or not? What are my chances? It's ASD, as you might be aware, is not such a very untreatable disease. It's not an untreatable cardiac disease, depending on, I'm not really sure which level it is, but most often atrial septal defect babies have been treated well and they have very good prognosis. So it's not something that can prevent you from trying for a second baby. And the reason for an ASD occurring may be many, and IVF is not proven to be one of the reasons for the ASD having occurred in your baby. So there would definitely be no harm in you trying for another baby, but considering your age, it's better that you try as fast as possible. And of course, a folic acid supplement in the meantime would help you as well. Next one. Next, please. Assuming that it's treatment for conceiving, as in with IVF, well, the current age limit has been set at 50. So after 50 in India, and as per the current ART bill, we would not be able to go ahead with IVF treatments. This is keeping in mind the health of the mother who is wanting to conceive. So the government has come up with such a thing that up to the age of 50, we can help the patient to conceive through an IVF. Can be done. This is a surgery for people who want to conceive after having undergone the tubal ligation. So this is a family planning procedure that some of them undergo after having desired number of children. So they do what is known as a tubectomy, where the tubes of the patient are tied up. So whether it can be recanalized again, yes, it can be recanalized, but the success with the recanalization surgery depends on a lot of factors, as to whether you've undergone the surgery by open laparoscopy, or whether it was a laparotomy, or whether it was how many years before this you've done, and how much of the tube has been ligated or tied up. So a lot of factors come into play, and the success of this surgery is seen to be around 70%. And before you go for the surgery, it's also wise to know that there is an increased chance of having an ectopic pregnancy. That is the tube which has undergone recanalization. So sometimes the pregnancy can get attached to that portion, and it can result in what is known as a tubal pregnancy or ectopic pregnancy. This can prove dangerous if not detected on time. So, but it's better to be aware of these complications. It's not that it happens to everyone, and then go ahead with the recanalization surgery. Yeah, so the success rate of IUI in normal fertile women. So when women are normal and fertile, then usually probably an IUI is not really necessary. It's fine to go ahead with normal ovulation induction. But if that has failed and you're thinking of an IUI because of the failure of ovulation induction, like I said, we've seen success of up to 30% in our center, and probably what we use here is super ovulation induction, wherein we give injectables to increase and to induce the eggs, to increase the number of eggs, and then go ahead with an IUI. So this is a slightly more expensive than using tablets to form the eggs, but the success rate has been quite satisfactory, in fact better than satisfactory. So we do IVF with super ovulation induction. So it has been quite, and we do double IUI. So you've asked whether the success of doing ovulation and previous day of ovulation. So that's exactly what we practice here. So that is called a double IUI. So we do 2 IUIs in a single cycle, and our success rates have been anywhere between 30 to 50% also at certain times. Thank you. So we come to the end of our session for today. I'm really thankful that so many of you joined and made it a very live and interactive session. In spite of the pandemic and the challenges posed by it, in spite of the delay that we had due to technical issues, and there were a lot of technical glitches, but this is our first time, and hopefully next time we will try to iron out most of these glitches, and we'll be able to reach out to you in a far better way. I'm really happy, I'm really glad that you made this a success. So our success is mainly due to all of you, and I hope that we've succeeded in clearing some of your doubts, if not all. Please be free to mail us to our email ID, which will be displayed, and we will try to accumulate these questions and we'll come up with a suitable topic. We're planning to have this webinar on a regular basis, so we'll definitely intimate you about the dates, and let's see how to go ahead. Thank you so much.